Hello and welcome everyone. Thank you for joining us. My name is Karen Eggleston and I'm Director of the Stanford Asia Health Policy Program. I'm delighted to welcome you to today's webinar, which launches our colloquium series for this academic year. I'm also Deputy Director of the Shorenstein Asia Pacific Research Center within FSI. And before I introduce tonight's distinguished keynote speaker, I wanted to talk a little bit about our colloquium series this year, which is entitled Health, Medicine, and Longevity, Exploring Public and Private Roles. You can look at our website for more detail about the upcoming events. This series will explore the evidence and experience of public-private nexus in health sectors across Asia in the current pandemic and globally, as well as beyond the current pandemic, with events throughout each quarter and a keynote in February 10th, 11 a.m. Pacific from Nobel laureate Oliver Hart, celebrating a quarter century of the proper scope of government, theory and applications. So more information is available at the Asia Health Policy Program website with links to each of the events where you can sign up for each of them individually or as a series. I want to call attention to the event 2 weeks from today, on Indonesia with Sujarno Sumarto, and then November 17th on chronic disease and COVID-19 with speakers from India, China, Korea, Thailand, and Vietnam. And in January with our own wonderful postdoctoral fellow, Dr. Jane, who's talking about government insurance in India and public and private hospitals. And as mentioned, a keynote of February from Professor Hart on contracting, public and private providers, and the theoretical framework for publicly financed services. So with that series, I'm absolutely delighted to introduce today's keynote speaker to launch the series, Professor Gabriel Leung. He's the 40th Dean of Medicine, inaugural Zimmern Professor of Population Health, and the Chair of Public Health Medicine at the University of Hong Kong. He was the last head of community medicine at the university, as well as Hong Kong's first Undersecretary for Food and Health, and 5th Director of the Chief Executive's Office. So he has a lot of experience in public policy and service in government, as well as being one of Asia's leading epidemiologists and global health advocates. He's authored more than 500 scholarly papers, and his research is to find the epidemiology of 3 novel viral epidemics, including SARS and the current COVID-19. As well as his work with Hong Kong government, he's advised many national and international agencies, including the World Health Organization, the World Bank, the Asian Development Bank, and many others. He's also served as editor or co-editor of many prominent journals, and is elected member of the U.S. National Academy of Medicine. Today, we're delighted to welcome to speak about the epidemiology, equity, and externalities of COVID-19 in public policy. You're welcome to enter your questions in the Q&A function. Welcome, Gabriel. Thank you so much for your time, and over to you.
Thank you very, very much indeed. I just shared my screen. Can you see that all right, Karen?
Yes, it's wonderful. Thank you. Please go ahead.
So thank you again for this invitation to give this webinar. I'm going to give sort of a few thoughts on the epidemiology, the equity, and the externalities of the ongoing pandemic, and very much look forward to learning from the audience in our discussion Q&A at the end of this hour. So first, just let me share this slide, which is from the end of January. So I distinctly remember that we got a call from the China National CDC on the 22nd of January, and we were on the first flight out from Hong Kong to Beijing on the 23rd. And from then on, it had been a very hectic week, looking at the first evidence on the epidemiology of the outbreak, and therefore needing to generate intelligence to inform public health control. This is a paper jointly done with the National CDC. And in fact, from looking at the first data set to this being uploaded in the New England Journal of Medicine, it was 6 days. And in those 6 days, we had worked very closely with the national team, looking at the first 425 cases coming out from Wuhan, which is in the middle of the country. So that's the first epicurve of the original epicenter in Wuhan. And from that data, we generated some critical distributions of core parameters that we need to inform public health control and to make public policy. So for example, this is probably the most important thing to learn about. Days for infection to symptom onset is otherwise known as the incubation period. And as you can see, this is the distribution, which means that roughly on the average, it takes 5.5, 6 days or so for people to actually first show symptoms. But as with most incubation periods, it's got a very long tail. And the reason that quarantine period is set at 14 days is because this would cover 99% of all infections. And you basically just need to look at the area under the curve here, and 99% is roughly where 14 days is. And that's really gone on to inform quarantine and isolation durations globally. And similarly, we have the zero interval, which is a good proxy of the generation time. That is, how long does it take for one generation to spread it to the next generation of infectees? And then you have these distributions, which will be much more time varying because they really look at how good your control effort is. And that is from the first suggestion of symptoms to medical attention or to being hospitalized. So what you want to do is to compress these distributions. And indeed, they are key performance indicators of many health systems to this day. Now, then what we did was to look at another parallel piece of work also done during the month of January. And this was really to look at the whole idea of the Spring Festival related travel, the Chunyun, which is the largest human migration on an annual basis on Earth, because as you can see, what we really worried about was this year, the Spring Festival related travel, Chinese New Year, started on January 10th, and it usually lasts 40 days. And we first heard about the first cluster of suspicious cases on December 31st. So we essentially had 11 days in terms of the time to the first day of that 40-day period. And what we did was to look at the mobility pattern that originates from Wuhan, which, as you can see, is smack in the middle of the country, and to then project using mobility data based on Tencent, which is the WeChat app, and some. They have the best coverage of mobility data in the country. And we tried to use that data to then say, if it spreads beyond the city of Wuhan, where might it go? Which are the cities which might get hit because of the Spring Festival related travel? So what we really wanted to do was to show what could happen, but not what would happen. So this is really just to make sure that we can plan public policy. And I think this helped to inform the nationwide so-called lockdown measures. And then this is the natural history. And if you have 25% reduction in transmissibility or 50%, then that is what could happen. and it's for all the major cities, all the major transport hubs in the country. Now, clearly, this did not happen, nor this for that matter. Rather, it was more like this. And so a couple of months after that, in March, what we did was we then showed what actually happened. Now, this is based on empirical data. This is from the epicurves of the major cities, Beijing, Shanghai, Shenzhen, and Guangzhou, just to show what the inferred real-time effective reproductive number was at different points in time. And as you can see, in some places, it did actually go above 1. That is, they did experience a brief period of exponential growth in that local epidemic in Shanghai and in Guangzhou. But then for Beijing and for Shenzhen, actually, they never reached that threshold of 1. And uniformly across the country in these 4 major cities, or if you look at the top 5 provinces, it's a very, very similar pattern. The epidemic, because of those physical distancing measures, which collectively has now been called lockdowns, all of these came under control, certainly by March, April. Now, then another very big question that we all had to struggle with was, what is the severity of this particular novel pandemic? Now, it's very difficult to tell in the early days what the severity was going to be, because it takes time for people to get sick. It takes time for people to be sick enough to be hospitalized and admitted into ICUs. And it takes time to resolve, that is, to know whether somebody is going to die of the disease or eventually recover. So you have to build these inferential models to try to estimate it in the very early days. So this piece of work was done sometime in February based on data from Wuhan to show the huge age dependency. So you can see that this is the symptomatic case fatality risk, and you see this exponential rise beyond the age of 50-something, 60. And in fact, susceptibility also rises exponentially. So if you were in this age group, you would be almost 1 whole order of magnitude more likely to be infected and then die of COVID-19 compared to people in this age range. And overall, the estimated case fatality risk of, say, 2%, assuming that 50% of the infections are symptomatic and come to medical attention. So if you are looking at an infection fatality risk, you'd be looking at about a 1% figure, which actually has held true to this day in most health systems. Now, if you sort of cast your thoughts back to SARS, this is SARS-1, back in 2003, it shows you why it's important to use robust statistical methods to estimate the case fatality risk. Because if you simply divide the total number of deaths by the total number of cases at any single point in time in an evolving epidemic, you will invariably going to get the wrong answer. So this is a simple, naive estimate during SARS, and it rose, as you can see, from 2% all the way to almost 20%. It's actually 17% in Hong Kong. But if you had used the correct methods, then you would be much closer to truth much earlier on in the outbreak. And conversely, if you always assume that it would go up, then you would be getting the wrong answer during the 2013 avian flu outbreak in and around the Yangtze River Delta, which subsequently spread to the south of the country, in Guangdong as well, because that case fatality risk actually fell from about 70% to 40% over time. And it's all to do with the distributions, those key distributions which I actually showed you in the first slide. So it's not something that is intuitive, and it does require robust statistics. Now, second thing, or second caveat of looking at the risk of death or the fatality risk is, what is your denominator? Are you dividing by laboratory confirmed cases, symptomatic cases, or infections? And you can see that they can mean 2 orders of magnitude difference. This is a log scale. And this is an example from the swine flu outbreak in 2009, which we all experienced. Now, here is the reason why SARS-1 in 2003 was amenable to being driven back into the wild, because the total case count globally for SARS-1 was fewer than 9,000 cases, which is about 1/4 of what the United States has just confirmed in the last 24 hours for COVID-19. So you can see the sheer scale difference by many orders of magnitude. And here is the reason why. So if you actually look at the time course of illness, so day 0 is essentially the first day of symptoms, and then if you follow forwards, and then you look at these things: temperature, onset of diarrhea, oxygen desaturation in the respiratory system, and then ARDS, which is very, very severe respiratory distress syndrome, requiring intubation. Now, you can see that this is very, very telling. So if, let's say, that you look at the viral load statistics, and then you look at the symptom statistics, you can see that basically somewhere around day 5 to day 7 after illness onset, that's when you get maximal symptoms. And this corresponds to the same thing here in terms of the viral load. So viral load corresponds with symptomatology, and what actually happened in SARS was you don't really start getting to be terribly infectious until sometime around here, around this time. So it gives you about 5 to 7 days from the infector experiencing first symptoms before you would need to isolate them and then quarantine the close contacts. And so long as you do it within the first 5-6 day window, you're probably okay. Now, compare that to, here is the corresponding viral load data for COVID. And this is a data set from Guangzhou number 8 hospital. And so essentially, you see, no matter how you slice the data, you get this kind of monotonic decrease where you have peak viral load at the time of symptom onset. And if you do more fancy statistics, which we did, and you look at this figure, it actually shows you that up to 44% of all infections to secondary generation actually happens before the index case even spikes first symptoms. And that's really the key reason why COVID is so much more difficult to control unless you take universal precautions, regardless of whether you have any symptoms or not, and that everybody does it at the same time. And that's really the key difference between SARS-1 and SARS-2. Another thing which is quite common across coronaviruses in particular, and COVID is no exception, is the clumpiness of infection. So here are some of the early statistics from the first couple of waves of Hong Kong, and you can see these are transmission diagrams, and these are very large clumpy clusters. So this is the very famous bar cluster, which exceeds 100 from a single super spreading event, the wedding cluster, the temple cluster, and then an assortment of the other cases. So you can see that it's highly clustered, and what it shows is, in fact, most 69% of the primary cases go on to spread to nobody else. They are terminal branches in and of themselves. And it's really the remaining 31% who go on and spread it to someone else. And in fact, it's highly clustered or highly over-dispersed in terms of roughly 15 to 20% of infections were responsible for 80% of all transmission events. And you see this repeated by several other groups and very similar solutions, very, very similar conclusions. Now, onto another maybe controversy in the lay press. Why did the WHO mask guidance change? I remember that it did change from saying probably not necessarily to don a mask for most people to please put on a mask universally. And here is why. So if you actually look at the pre-COVID evidence base, you will see that out of all the randomized controlled trials that were done, and it was fitted in this meta-analysis, there is some suggestion that a point estimate of somewhere between 10 to 20% reduction in flu transmission is associated with universal mask use and enhanced hand hygiene. And in fact, these studies were mostly funded, including ours in Hong Kong, by the US CDC about 15 years ago. And so, but you will also see that it traverses the 95 confidence bounds, actually traverse the unity value of 1. So it's not so-called statistically significant. And that's the evidence base for influenza transmission in the community prior to COVID. Now, if you then look at a rapid review that was published recently in The Lancet for SARS, MERS, and COVID, but mostly in healthcare settings, it shows that this diamond down here shows a remarkable reduction of the utility of face mask, probably somewhere around 44%. Nevertheless, if you actually just look at the non-healthcare settings down here, all right, there were actually only 3 studies referring to non-hospital settings, and one of them actually refers to mask use of visiting family members in hospitals, so it's actually a healthcare exposure. So we're really not certain about this either. Now, all that said, if you then look at some of the mechanistic studies, we have collaborated for a long time with Don Milton at the University of Maryland on looking at mechanistic studies of virus in exhaled breath. And what we've found, and published recently as well, is that for human coronaviruses, and we're talking about the 4 seasonal coronaviruses, not COVID, but we don't think that they're any different. If you put on a mask, actually virus cannot be isolated in those experiments, whether it's by aerosol spread or by large droplet spread. So this is quite significant evidence. However, even with universal mask use, as you can see the red dots here, so Hong Kong has basically had universal mask use since the middle or the end of January onwards. We still had, as you can see, this wave and then this wave that we just came out of. So even with universal mask use, we still had these waves, which suggests that mask use is probably necessary but insufficient to stop large outbreaks. But we note that most of these cases actually came from places where masks are not usually worn, like bars, restaurants, gyms, elderly homes, and migrant worker dormitories. There is now a trial which I think has just finished recruiting, and I think that I have just been asked by one of the journals to review this paper. I haven't looked at it yet. This is a Danish study with 6,000 adults randomized to wear a mask in the community or not. And so I very much look forward to peer reviewing this paper, which is in my inbox this morning. So the state of the science really is limited evidence base for face mask effectiveness for flu, but the data are consistent with a 10 to 20% reduction in transmission. Mechanistic studies says that yes, it can provide source control for both droplets and airborne spread. And it does say that it can provide protection And I think that the argument of masks don't have 100% effect in stopping transmission, therefore they're useless, is really fallacious, because if there were a drug that gives you a 10 to 20% reduction in preventing you from getting infected, I think it would actually be a blockbuster drug. So one more thing is, it's probably necessary but insufficient. So another very controversial issue, school closure. What is the evidence there? If you look at the, this is a very elegant Nature paper from Kaushimes. It's actually not 2020, I beg your pardon, this is a typo. It's probably a 15-year-old, 10, 15-year-old paper, looking at the rotating school holiday season in France nationally, and inferring that school closures actually helps in reducing the transmissibility of the seasonal influenza outbreaks in France during holiday time. Now, if you then look at 3 instances where Hong Kong has closed schools, again, to control influenza in 2008, in 2009 during the pandemic, and in 2018 during the flu B season, it's very difficult to foretell whether they would work or not. The only time that has worked quite substantially is during the 2009 swine flu pandemic, where we had an early summer break for all schools, which reduced transmissibility by somewhere around 12 to 25%, and the peak was delayed. So we were able to stretch out and mitigate that pandemic. It didn't work in 2008 because we did it too late. And in 2018, for the flu B outbreak, we did manage to reduce transmissibility by some 4%, but probably it's not a very large effect. So it's very difficult, it's fairly mixed evidence to say whether school closures would work categorically or not. I have been very impressed and inspired by this paper by Mark Lipsitch, and importantly, his better half, Myra Levinson, who's professor of education at Harvard as well. So they put together a paper in the New England Journal arguing for reopening primary schools during the pandemic. And this is one of the concluding paragraphs. It says whether and how to reopen primary schools is not just a scientific and technocratic question. It is also an emotional and a moral one, and our sense of responsibility towards children to protect them from the vicissitudes of life, including the poor decision-making of adults who allow deadly infections to spiral out of control, is core to our humanity. Now, if you actually look at the education division of the World Bank and looking at their model of some of the key outcomes, whether it's learning adjusted years of schooling, average learning loss, and share of learners below the minimum proficiency level, which, by the way, is an SDG in and of itself. So in the base case scenario, you see that there is a 7% reduction in the learning adjusted years of schooling, which would give you or translate into expected earnings fall of about 800 or 900 PPP dollars per year per student. And the average PISA score falls by some 4%, and that would push about 25% more students into those who actually would fall below that minimum learning level. Now, so very recent evidence published in JAMA, I think a month or two ago, looking at all 50 states in the US where schools closed in the middle of March. And what they did was essentially it's a lagged Poisson time series model. And they showed that there is this very, very nice bending of the curve. This is the epi curve. And with this intervention, there is this inflection point for both incidence and mortality. Now, the trouble with this analysis is there is no positive, no negative control because this was implemented all through the 50 states. The adjustment of co-varying non-pharmaceutical interventions like physical distancing, like mask use, and everything else is insufficient because they all were collinear with school closure. And the plausibility of the effect size of 60% reduction is probably way too high unless we've all been missing something. And I'm going to show you a comparative table to demonstrate that point later. Now, so what we did, and currently this is in the final stages of review, so hopefully it will see the light of day sometime soon. What we actually did was to take two very detailed case contact line lists from Shenzhen and Anqing. This is in Anhui province, by the way. And this, of course, is just next door to Hong Kong, to look at the relative susceptibility by age and the relative infectiousness by age. You can see that relative infectiousness is probably sort of quite flat. If anything, kids probably are relatively slightly more infectious by somewhere around, 50% compared to adults. But you will see that they are not nearly as susceptible, as you can see here. They're, again, depending on what age group, but look at this. 20 and under, it's around about 0.2, 0.3 of adults. So knowing that, if you then fit this kind of age susceptibility and infectiousness in a synthetic contact matrix, and the Europeans have done a lot of work on this for the last decade in many different European countries. They generate these from survey data of a large number of European countries, and then they update it in these synthetic contact matrices. And if you do all that together, and then you look at COVID compared to flu, you will see stark differences. Essentially, if you close schools for COVID, you might at most reduce the R0, or the basic reproductive number, somewhere around single digits. All right? And then the different colors are the different contact patterns in different countries by developmental stage around the world. But the message is, it probably doesn't work nearly as well as if you had done it for the pandemic. Look at this. Similarly, the control threshold, that is, what would the R0 need to be already in order for the school closure to push it below 1? And essentially, you can see it could only be somewhere around just above 1, which means that school closure for COVID, it's not your main determinant or shouldn't be your main arsenal. Whereas for flu, you could actually potentially push, especially in high-income countries, a pandemic that rages on at an R0 of 2 back towards below the unity threshold of 1 had you close schools. And similarly, what might you need to do in order to have the same effect of school closure? And for flu, you would basically need everybody to stay home in order to replicate that effect of school closure, whereas you could do a lot more else to replace school closure in the COVID-19 situation. This simply shows for different R0 values, what would be the absolute and relative reduction that you could expect for different age groups if you had been thinking of closing schools for COVID. So it's just a different way of looking at the same data. Now, moving on to equity. This is, again, fresh off the press, showing the inequality or the inequity of COVID distribution in terms of those who get sick and die from it. You can read for yourselves. This lays very bare the huge inequity of COVID diagnoses and death. Similar data of Black, Asian, or multi-ethnic groups in the UK, you see very similar patterns, and also the male-female divide. Very, very distressing, unequal picture. And even in Singapore, a city-state, you can look at, this is the attack rate in the general population, 0.04%. The attack rate amongst migrant dorm residents. These are the workers who essentially are the ones who do all of the less desirable work in Singapore, and their attack rate is 17%. There is a 400x difference. Quite startling. And Bentley has proposed recently what might these structural inequalities be explained by in this quasi-DAG diagram. I think the real test for the rest of the world is, given that we have already, mostly by omission, committed the gravest health inequity in the last century, arising from a single event, I think that it would be very telling what we do with getting shots into arms in terms of vaccine allocation. And Zeke Emanuel, brother of Rahm Emanuel, who is a professor of medicine and ethics at UPenn, wrote a very good article in Science that came out in the last few weeks of what in his mind is fair distribution of vaccine. And I would encourage you to read that paper. Now, of course, the impact of COVID on global extreme poverty is quite dire. It's quite dire. You can see that all of the gains that we had been able to do in the last few years is now almost completely lost. Almost completely lost. And by different poverty lines, you can look at the differential effect by global regions according to this World Bank projection. Of course, these are the other externalities of the pandemic, whether it's about education, particularly college education. Karen was just telling me that none of the key cards work on the Stanford campus, as with many campuses around the world. A new world disorder, as the economists put it. You can see the panda, and the nose is actually the continental United States. The shifting geopolitics, trading without trust, business of survival, global commerce. You can see very different performance, at least according to the stock markets, of different types and sectors of firms. Globalization or deglobalization for that matter. And then what is the read across to climate change or planetary health? And in particular, what about the migrant story, the global migration story that we've all been following and working very hard on? I think that there is going to be a very different outlook post-COVID. I would encourage you, unless you have already read it, read this magnum opus by Ed Young in The Atlantic. Very interesting read. And then try to also get this book or booklet. It's a very quick read from Levy about his take on the virus in the age of madness. And also it's quite an interesting read of a philosopher really pitting himself against a lot of the medical dominance in terms of the conversation and the thinking to this pandemic. Last but not least, couldn't have done it without these people. and they are the team leaders, really, of the Hong Kong U effort in our research for COVID-19. And these are our funders who have been supporting our work for many, many years, really since the time of SARS. So thank you very much indeed, and looking forward to learning from you in this Q&A session.
Thank you so very much, Professor Leung. So while others may put your questions in the Q&A anytime, we'll start with some questions that had come in earlier. As you mentioned, there are lots of controversies about many different aspects of controlling this pandemic. Thank you very much for your careful and nuanced treatment of the science related to that. In one aspect, you had asked about education. So one of the questions you focused on schools and then alluded to colleges. So what would you say about that college age group? Some universities, including Stanford, have graduate students but not undergraduates on campus, given the closeness of dormitory living. So what would you say about that intermediate age range of college students?
Well, I think college students are no different than adults, really, in terms of susceptibility and in terms of relative infectiousness, as I showed you the data. And I think what we need to be very careful about is trying to be explicit about the trade-offs, the risk trade-offs. So I think that the three-way tug of war between health protection, economic preservation, and the implied willingness or the emotional well-being of the population to go along with the control measures. So this three-way tug of war is not going to end until there is resolution to the pandemic. And it depends on the context, which of the three almost orthogonal forces are going to determine ultimate policy decisions. In terms of college students, it really depends on what kind of collective consensus that particular population may have vis-a-vis, on-campus activities, classroom activities, extracurricular activities. There is usually no higher risk on campus compared to the general community if you follow universal precautions. And if you're careful and serious about physical distancing, about personal hygiene, about how you structure your activities. But if you think about what could happen if there were no such consensus, then yes, that might lead to very high risk settings, very high risk activities, very high risk behavior. And indeed, we have seen that in a lot of European countries, as well as in many states in America. And that has been shown time and again over the last couple of months to be the major transmission age groups or age bracket. So it really depends on what you do. The Hong Kong U campus is open, as are quite a few in East Asia. But I think that that's against a different background because for example, in Hong Kong, we've had 5 new cases yesterday out of a population of 7.5 million people. I think that given that the community transmission is at a very low level, I wouldn't say negligible, but very, very low level, then I think that you can afford to reopen campuses and allow a new normal of functioning to carry on, because you simply cannot go on like this with perennial lockdowns for, say, the better part of the coming 12 months.
Right, thank you very much. So going to a question that others have come in. One is, why does the flu behave so differently in respect to mask wearing, something you talked about compared to SARS-CoV-2? What are the features of the virus or its transmission? And if you could, what was the percentage of asymptomatic transmission? I think you had mentioned. So we would like you to address those.
Right. Well, why does flu behave so differently? Flu doesn't behave so differently. I think that we haven't actually seen flu seasons since COVID, anywhere in the world for that matter. And that's because they share very similar modes of transmission. And if you are doing everything you can to prevent COVID transmission, you would also have the added benefit of preventing flu transmission. So I'm not sure that they are really very different in terms of mask wearing. In terms of asymptomatic transmission, for SARS-1, there's basically none. If you were infected with SARS-1, you will present with symptoms, and quite seriously at that. We know that from serosurveys or serological surveys. For SARS-2, the proportion of asymptomatic is probably somewhere around 20%, according to the latest meta-analysis. So it's a very, very different type of bug.
Thank you. A related question having to do with schools and school closures, those issues. Again, one of our attendees wants to know what are the effects or factors related to culture as well as those MPIs that you talked about. So for example, we know in many communities in Asia, the norm of universal mask wearing is more salient or stronger. And what do we know, say, compared to states or in Europe or elsewhere where that may not be as well accepted?
Well, I'm not sure that I have the answer, but I think that prior experience has a lot to do with it. And so, for example, in Japan, in Tokyo, wearing a mask has been part and parcel of living in the city or living and working in the city of Tokyo years before any of this happened. And it's not SARS either, because Japan actually didn't have SARS. So was that because of very crowded conditions? And was it because of roadside air pollution? Was it because of this general hygiene or cleanliness context? I don't know, but I suspect it's probably all of the above. And as for, say, Korea, which had MERS, Hong Kong, Singapore, Taiwan, mainland China, we all had SARS, including Toronto, by the way. I think that, that sociological imprint is deep. So if you compare the Canadian response with the American response, you see a very important difference as well. And lastly, I don't think the politicization of mask wearing has been at all helpful. And I think that must also be taken into account.
Thank you. Another question related to looking forward, what to expect in the coming months and year. What are your views, for example, about vaccines? You published about that and its combination with other measures that might be needed. Some people view it as a magic pill. As soon as it's there, we'll revert to normalcy pre-COVID. And related to that, what about WHO COVAX and China joining and the US not? Any thoughts about all of those?
So I think the first generation of vaccines, the 10 or so or a dozen that's being trialed in phase 3 studies at the moment, I think with maybe one exception, possibly, none of those dozen actually provide sterilizing immunity, i.e., they can probably reduce mortality and serious morbidity, but they probably won't stop infection and therefore transmission. And so I don't think that it's the silver bullet that everybody has been hoping for, but I think it's a necessary bullet in our tool belt so that it allows us to incrementally go back to pre-COVID normalcy. But it's not going to be the silver bullet that people are looking for, that this is going to stop the pandemic in its track. Not least because, number one, the first generation vaccine science hasn't got there yet. We may get there with the second or the third generation. Secondly, it's a logistical nightmare to produce, transport, and distribute to 7.5 billion people. And just remember that we are as safe as the weakest link somewhere in some corner of the world. And therefore, it's going to be a little while before we can say we're completely free of this COVID threat.
Thank you so much. Somewhat related, you were also the director of the Laboratory for Data Discovery for Health at the Hong Kong Science and Technology Park, as I understand it. So I wonder what you would say about initiatives like that and public-private roles in addressing this and future epidemics and health challenges.
I mean, I think that, data science has a very important role to play, has had already a very important role to play in the COVID response, and it will carry on being very, very important in all myriad ways. There is a thing called the Trinity Challenge, which is led and convened by Trinity College, Cambridge, bringing together public actors, including multilaterals, and private sector and academia together, specifically looking at how to bring about data-driven policies in the light of COVID so that we won't have to face something similar, perhaps not forever, but at least not for a very, very long time. And I think that it's absolutely crucial to leverage on what technology has enabled us to do while respecting privacy, confidentiality, and also making sure that there is watertight protection of data.
Thank you. Another question related to that, of course, there's a question, what do you think of the Apple Google coronavirus tracing apps and other apps? And a question about how they're applied in different parts of the world.
Well, I mean, I think that, contact tracing apps generally can be useful, but it really depends on the level of trust people have and the level of adherence that they have for something like this. No app can help you unless there is general willingness of the majority of the population actually using it. And that, I think, is just so critical. And that's why governance and trust in good governance matters. And, it's really as simple as that.
Thank you. You mentioned and rightly emphasized the huge disparities that are being revealed and ongoing during this pandemic, locally and globally. One of our listeners is asking, what do you think are many of the factors related to that? You mentioned in Singapore, for example, the living conditions. Are there other factors? More broadly, structural inequalities and what has to do with other measures that are more proximate. Your thoughts about those factors that are causing the disparities and what we might be able to do about it in the near and long term.
Well, I mean, I think that there is nothing quite so toxic than the toxicity of poverty. That we've known for a long time, and that is something that is pervasive. It's not just restricted to COVID, but with COVID, you see it time and time again. And it merely just reveals, yet again, another example of the toxicity of inequity. And so I think that there is nothing so special about COVID per se, as opposed to the structural determinants of these inequities, including that arising from COVID. And I think that rather than trying to have vertical programs to reduce inequities for COVID only, I think that it would be much more fruitful and much more useful to address those underlying determinants which transcends disease types. But importantly, I think, as I said, the litmus test for the world is how do we ensure fair allocation of vaccines?
And related to that, what do you think are the most important factors that are going to assure fair allocation of vaccines?
I'll leave you to read Zeke Emanuel's paper in Science. He actually wrote a more generic version of it about allocation of resources for COVID-19 and any emerging disease in the New England Journal. So read those two papers. But I think that it's really the politicians and the multilaterals which need to make it happen. It's not what we understand. I think the principles are almost self-evident. The crux is, how do you get it and translate it into political action? Because ultimately, that is what determines vaccine allocation. That is ultimately what determines public policy.
Thank you. Maybe last question, one that has come in. What do you make of the theory or some evidence about mutations of the virus? Some have said that there are mutations that are becoming less or more lethal. What are your thoughts?
No, I don't see any evidence anywhere of changing lethality or fatality. So I'm not sure that there is any good evidence to show that the mutations that we are seeing in the virus sequences have any effect on clinical severity. What we have seen is greater transmissibility or greater ease of transmissibility from that D614G mutation that has predominated since March, actually globally. That we've seen evidence of, but no mutation that I'm aware of that shows severity impact.
Well, there was just one more that had come in the last minute. Then there's a question about when and who should get vaccines first. I know you referred us to those readings, and many of us have done and appreciate. Thank you very much. When would you know, or your colleagues there know for sure that a vaccine is safe, effective, and ready to be distributed?
Well, I mean, I think that it really depends on your national FDA equivalent. And ultimately, you need to have approval from the national regulatory agency responsible in order to get vaccines imported or distributed, or both. And I think that's the ultimate test for each and every national jurisdiction. I anticipate that you will start seeing vaccine supplies come on stream sort of sometime by the end of the year, maybe early next year. But it would take a year or two to vaccinate the entire population of the world. So it's an evolving process, and I hope that it will go smoothly, fairly, and expeditiously.
Well, thank you so much. We appreciate that, and others who will be able to view the recording and understand what you've said about domestic and global implications of this current historic moment and the pain it's causing for many around the world. Thank you so much for sharing your expertise, Gabriel Leung, and thank you all very much for listening, and join us for later events in this series. Thank you all very much.